Hey, everybody. Thanks for joining us today. I am Kathleen Morris, and with me I have,
Erik Zetterberg.
and we are estate planning attorneys based out of Johnson City. We also work in Georgia. And we are here to give you guys some legal information, not advice, about things that we get asked all the time and just information we think is going to be really helpful to have out in the public because this is important stuff that is part of doing life. Today, we are talking about the advanced directive for healthcare and why it's important, what it does. So let's go ahead and look at that now. Specifically, as we are primarily, both of us are licensed in Tennessee. I'm licensed in 5 jurisdictions. When I say Tennessee is my favorite form, I think it is the best form out of the states that I'm licensed in. And I've actually sometimes incorporated it into forms for other states when I felt like that was appropriate. So I think this is a great thing to go through, even if you are not a Tennessee resident, because I think it makes you think a little bit deeper about, or more specifically about different situations and what types of care you would want in a little bit more specific situations.
Yeah,
Um,
definitely agree with that. I have people all the time say, "Hey, I've never thought about this. I'm glad we're doing this."
yeah, for sure. So what I'm going to do is I'm going to go ahead and I'm going to share my screen and I'm going to show you guys what the Tennessee form looks like. And we'll give that a second to pop up. And we're just going to walk through it like you guys are in the room with us, how we normally go through with clients and talk about it. In this example, just so we don't have blanks, we know what goes in there. We just pick George Washington as the client in this situation, right? So the first thing you're going to see on this form is you say Advanced Directive for Healthcare. So what is that? This is a form that is specific to giving end of life instructions to the person you want making your healthcare decisions if you cannot make them. This is not you're in a car accident and they come across you unconscious, right? Nobody's looking at this document then. This is for known end of life situations is when this document gets used. And so the first thing you'll see is it says, hey, this is the client, George Washington. These are my instructions. Okay. And then it lists the agent. And very importantly, it has the agent's contact information. And we strongly recommend, and the form provides space for a primary agent and a backup agent. And when you're talking about who or thinking about who you're selecting to be that agent, there's not necessarily a right or wrong answer, except that I would suggest if you have someone who you are a pull the plug type person and that's going to destroy them to have to do that, maybe you want to pick someone else. If you have someone who has a severe history or like a history of severe depression, significant mental health challenges, right? We don't want to be choosing people who are going to have to make decisions that's going to more significantly impact their well-being as compared with an average person, right? It's never pleasant, it's never fun, right? This is not an amusement park ride, right? This isn't something that's enjoyable, but there are definitely some people who just it's not good for them to have this kind of responsibility. So that's really the only thing that I say would exclude someone from being chosen as a that your healthcare agent in this decision. So we want to pick our people wisely. Usually, people who are married pick their spouse, and then if they've got kids, they've got a kid, parents, friends. And even if you're married, you don't have to pick your spouse, right? Not every spouse is the right person to be making those decisions. So it's really a personal decision and something you want to talk to whoever you're choosing about ahead of time, if possible. So then you're going to have the contact information, right? Basic phone number, address. You're going to say what their relationship is to you. And then the first question that gets answered on this phone, and I'm highlighting this here so hopefully you guys can see that. So you're going to make a choice. And you've got two options. And the first one says, I give my agent permission to make healthcare decisions for me at any time, even if I have capacity to make them myself, right? So that means, hey, even if I'm fine, they can make decisions. If you're fine mentally, I should say, they can make decisions. The second box is I do not give permission. And so the form only applies when you don't have capacity. And I don't know about you, Erik, but a lot of times the question that I get here is, oh my gosh, who would ever pick number one? I think,
Yeah.
yeah, I tell people it's more of a personality test than anything else.
Yeah, yeah. I have had one or two times where somebody said, nope, I want them deciding. And it actually was that situation of somebody who, my client actually was somebody who had a very difficult time making decisions, had some mental health things going on that made it so they didn't want to have to bear that burden. They wanted to say, no, I really just want to hand this off
Yeah.
to my spouse or to who or my kids. And it's few and far between, but there are a few people who really do want to say,
Yep.
you decide. I don't want to have to do that, which is why the box is there. But the vast majority of people pick number two.
Yeah, the other situation where I see people picking the top one is if they, particularly married couples, if one person is very non-medical and doesn't like that stuff, and their spouse is a PA, a nurse, a doctor, something like that. I have seen it in those circumstances as well. But again, most people are choosing the first box. And the other question I always get, should I color it in? Should I exit? Should I check mark it? It doesn't matter. So,
Yeah, just do the same thing on all of them. I don't care
yes,
which one you do, but once you pick one, stick with it.
yep, for sure. All right, so now let's move more to the meat and bones of this form. And the nice thing about this form is it's 2 pages total. It's not super long, but we do have a couple different sections to work through. So you'll see in this top section where it says to indicate your wishes for quality of life, right? There's some options there. And then you'll see down here, you want to indicate your wishes for treatment, and there's some options there. And the way this works together is basically the top situation, top choices you have to make are conditions of life you might find yourself in, right? And how you select that, if you put a yes there, basically nobody's going to look any further. They're just going to try and keep you going, right? Like you basically are saying, I'm comfortable with this. I'm okay with this. Give me all the interventions. The no answer is really a toggle to say, hey, look below now and see if I'm in this condition, do I want this treatment or not? And I think giving that framework before we go through it helps, or at least helps my clients to understand it a little better. And I
Yeah.
also
I
give,
always jump in and say, hey, think of it like a flow chart. Like we look for the first section, and then if we've met that requirement, then we go to the next arrow down and say, okay, now what do we do because we met that requirement? I find that kind of helps people think of it in that way. It's okay, first, is the form even effective? Then what's our quality of life? And then what treatment do we want? We don't move down to the next part until we've met the requirement for the one above it.
yes. The other thing I like to tell my clients before we start answering this, is particularly when I've got spouses in there together, is I say there are no right answers on this form and there are no wrong answers on this form. And you are not required to copy your spouse's answers, but you are allowed to copy your spouse's answers. And nothing you mark on this form is going to cause someone to artificially shorten your life, hold a pillow over your face, or Dr. Kevorkian you. If those are your wishes, you need to move out of the state of Tennessee or find someone to break the law for you, which I'm not advising.
Yeah, I get that question a lot when people are like, okay, now if I mark no, and then and I'm in this condition, then what happens? And I'm always like, we're not going to take you out back behind the woodshed. That's not going to happen. It's just saying, hey, if I'm in this condition, I don't find that generally to be acceptable. So there are some situations or some treatments I might not want to have, given
Yeah.
that my life is already pretty rough. Because as you'll see when we go through,
Yeah.
these are describing some pretty grim life conditions to
Yeah.
be in the first place.
Yeah. So let's go through it now. So the first section says we're going to indicate your wishes for quality of life. By marking yes below, you're indicating conditions you're willing to live with, given adequate comfort, care, and pain management. Marking no below, you're indicating conditions you are not willing to live with that to you would create an unacceptable quality of life. And so the first one you'll see there, it says permanent unconscious condition, where you're totally unaware of people or surroundings with little chance of ever waking up from the coma. So this condition is pretty self-explanatory. I think people understand what a coma is. You are non-responsive, likely on life support, some type of life support. Obviously, that can be varying degrees of support there. So if you want to be kept alive and going in that condition, you want to mark a yes. And if you would want to limit life extending care in that situation, you'd want to mark a no. The second one is permanent confusion, and that's where you become unable to remember, understand, or make decisions. You don't recognize loved ones or cannot have a clear conversation with them. And Eric, maybe you can talk about some situations where this might be the case.
Yeah, so I typically describe this to people as your first thing is not that you just lose your keys 3 times a day every single day, right? Or even that you've got beginning stages of Alzheimer's or something like that. We're talking about you are in advanced stages of some kind of mental condition that has caused your brain just to not work. the same anymore. For me, it's a very personal one is my grandmother who's 98 years old, who cognitively is a 2 or 3 year old. And so she just is really probably not that far away from being at a point where really she just hangs around. I will say, like this last Christmas, I don't know that she really understood what Christmas meant. She understood it was a day where everybody was together, but she didn't really know why. And so that's how I describe it to people is you're the grandparent sitting in the rocking chair because it means something to everybody else in the family that you're there, but you really don't understand why you're there, why it's important that you're there, that kind of thing. It's advanced to that level.
Yeah, I think that's great. Thank you. So again, if you are okay in that condition and you want as many interventions as possible to keep you going, you'd want to mark a yes. I shouldn't maybe say as possible, as is medically reasonable. But if you'd want to limit some of those life extending care, you'd want to mark no. So the next one is dependent in all activities of daily living. This is where you're no longer able to talk clearly or move by yourself. You rely on others for feeding, bathing, dressing, and walking. Rehab and other restorative treatment will not help. Example from my family is my step grandmother passed away with ALS, and she definitely would have fallen into this category. Other neurological degenerative diseases could put you in this situation. A stroke that you don't recover well from could put you in this situation. Do you have any other insights on that one, Erik?
No, I think the piece of this that everybody really they first read they start reading it and then they start getting like worried, okay, gosh, like that's real bad. And then we get to okay, and then now also rehab and restorative treatment. We've already done everything we
Yep.
can. Right?
Mhm.
There is no getting better from the condition I'm in. That's the key piece for a lot of people because they're like, but my mind could be fine, but physically I may just be limited. I'm like, okay, yeah, but we're at the point where there's nothing else to get better.
Yeah. And where's the point where you don't want to be kept going in that condition if something
Right.
else were to happen to you? Yeah. All right, and the last one is end stage illness, where you have an illness that has reached its final stages in spite of full treatment. Examples include widespread cancer that's not responding to more treatment, chronic and or damaged heart and lungs, where oxygen is needed most of the time, and activities are limited due to the feeling of suffocation. So this could be a lot of things. They give the cancer example in there.
Yeah, and I think that again, got time back to the last one, the in spite of full treatment. That's the key phrase there. It's medically, doctors are coming and saying there is nothing else we have for you. You've
Mhm.
done the clinical trials, you've done the chemo, you've done all of you've searched outside of even our country and gone into Eastern medicine and
Yes.
tried some other things and gone holistic, and at this point nothing else is making it better, right?
Yep.
That's the progression we're talking about in this
Mhm.
situation.
So if you want to be kept alive as long as reasonably possible in that
Right.
condition, you would want to mark yes. And if you would want to not have life extending treatments in that situation, you would mark no. Which then brings us to our next section, and that is where you're going to indicate your wishes for treatment. So if your quality of life becomes unacceptable to you, and that's going to be indicated by all the no's that you've marked above, if any, and your condition is irreversible, meaning there's no medical reason they think it's going to improve, you're directing that medically appropriate treatment be provided as follows. You want to mark yes if you want the treatment in one of those no conditions above, and you're going to mark no if you would not want that treatment. And again, remembering that this only applies in those known end of life situations that you've just marked. So the first one is CPR. I think we all know what CPR is. It's to make the heart beat again and restore breathing after it has stopped. It usually can involve chest compressions, electric shock, and breathing assistance. So if you want CPR, you would mark yes. And if you didn't, you'd mark no. And Erik, maybe it'd be helpful if we gave them an example of where this could come into play.
So the easiest kind of example there is, okay, I'm in stage 4 cancer. I've finished my chemo rounds. I've gone through all the clinical trials I can. There's nothing left. Doctors have said, look, you've got 4 months at most. There's nothing else I can do for you other than keep you comfortable. And then 14 days later, you have a heart attack, right? And so in the event that for that type of that situation, would you want CPR done on you, given that CPR, it looks nice and pretty in the TV shows. It's super
Right.
easy. A little bit of water comes back out of your mouth and you're breathing again. Everybody's fine, right?
Yay!
In real life, it's a very bones get broken and it's a very traumatic thing for your body to recover from.
Yep.
And so, given that you may only have a few months to live anyway, you really wouldn't want to live those last few months trying to recover from a broken rib.
Mhm.
And so you would probably in that situation, a lot of people want to say, you know what, at that point, if I'm being called to the great beyond from there, then I'm
Mhm.
ready to go.
Yeah.
And so go ahead and just don't worry about the CPR. Let me pass on peacefully rather than putting my body through all of that extra stuff.
Yeah, for sure. All right, so the next one is life support and other artificial support, and that's the continuous use of a breathing machine, IV fluids, medication, and other equipment that helps the lungs, heart, kidneys, and other organs continue to work. So I think a lot of people have an understanding of what life support is and if you would want to be kept on that. I do think one of the things to point out here, because one of the questions that we get a lot is, how strictly is this enforced? If I'm not kept on life support, does that just mean immediately it's never used? And I think this is a good opportunity to talk about the gray area of life and dying. So for most people, it's not an immediate thing. And example from just last year with my mom passing, my mom was a like all knows person basically. She was a let me go see Jesus person. Um,
Yeah.
and I was out of town. I don't live there. And they basically continued to treat her so that she could have some cognition and give me time for me and my kids and my family to get there and to say bye. And she was an all knows person, but in those moments, they're going to most often, assuming their agent that you picked is on board with this, give the agent time to come to terms with what's happening, give the family time to come in to say goodbye and to do those types of things. So even if you're an all knows person, I think it's important to understand that there is this kind of gray area and this transition from what may not be a known end of life situation to something that is a known end of life situation, and understanding that's why we pick agents to that we trust, that we value their judgment to use our guidelines to walk through those gray areas as well. All right, next one, treatment of new conditions. So if you want new treatment, new conditions treated, you mark yes. If you don't, you mark no. And so what is that? That's the use of surgery, blood transfusions, and antibiotics to deal with a new condition, but will not help the main illness. And maybe, Erik, you want to talk a little bit about what that looks like?
Yeah, so this is definitely one of the ones that I think clients have a tough time answering because it does cover a very broad range of treatment. And so the reminder there is always, this is always given adequate comfort care, right? So there are times where antibiotics or if you've got the flu, Tamiflu is comfort care, right? What you're really trying to decline here, if you mark no, is to say, look, if I've got stage 4 cancer and my knee blows out, stabilize my knee, give me whatever pain medication I need to keep me comfortable, but don't go in and do a full-blown knee replacement on me when I've only got a few months. And then blood transfusions and there are certain types of even antibiotics that can really wipe out your system, right? And so you might want to decline some more aggressive types of treatments and say, look, just give me the bare minimum to keep me comfortable until whenever it's time to go. And so having that little bit of reminder of the context of when this is coming in is that in that comfort care is really good. But it's really just saying don't do anything that's going to be super invasive, super hard on my body, given that I'm already in a condition that I find unacceptable.
Yep. All right, and the last one, the last box to check here is for tube feeding and IV fluids, and that's the use of tubes to deliver food and water to a patient's stomach, or the use of IV fluids into a vein, which would include artificially delivered nutrition and hydration. So if that's something you would want, you mark yes. You can also mark no. I've had clients in the past who are okay with limited use of that and they'll put a time frame on it. I've had some where we can interlineate and write, hey, I'm okay with any fluids, but I don't want a feeding tube. I don't want that kind type of thing. So you can definitely notate this to more accurately reflect your specific wishes and desires here.
Yeah, I definitely agree that the pushback I get the most on this is the IV fluids from people is I'm okay if I've decided to stop eating, like then that's how my body decides to go. That's
Mhm.
fine, but I don't want to dehydrate to death, right? And so that's a common one that people want to say, hey, yes, generally, yeah, keep me hydrated,
Yeah.
right? I don't want to be thirsty for the last few days of my life.
Yes, and that's actually something that I have noted on mine where it says other instructions underneath, and we can talk about that a little more in a second.
Mhm.
But I have done some court-appointed guardianship work, so I have been appointed by the court to help people make decisions when there's a ward of the state, because the weight of the medical system is to keep alive, keep alive, keep alive. And at a certain point, the doctors start to feel like they're hurting people by keeping them alive. And that's usually
Right.
when the court gets involved, when there isn't these documents in place and there's no family to step in and do it. And they will say, hey, don't give water because they can aspirate it, they can get pneumonia, make it worse, blah, blah, blah. And I've just, with some of the situation that I've seen, I've told my agents, I was like, I don't care if I get pneumonia. If I want water, put some water on the sponge and give it to me. They've got these little blue sponges where you can put it in your mouth. And I was like, give me chapstick, give me water, give me chocolate. Like those are things you can't deny me at any point in my life, because if I'm at that point and that's going to kill me faster, okay. But so you've got your own personality, your own things that you've seen, your own
Right.
experiences, the things that you're worried about, right? So that's a great place here at the bottom where it says other instructions, where if you have those types of desires, end of life wishes, go
Mhm.
ahead and write it down. Talk to your agent about it.
Yeah, and as you see on the bottom of the form, attach additional pages if necessary. Don't be afraid if you've got specific things
Mhm.
that you want to make sure are honored in specific situations, go ahead and put them there. I've had everything from one client who wrote, I filled up those lines there and flipped it over onto the back and filled half the back page with exactly
Mhm.
where his ashes were to be buried and that an apple tree was to be planted over top
Yeah.
and all of those things. And this is your document that when it's time for you to pass on, this is what's going to tell
Yeah.
your family what you want. You need to take the time to put
Yes.
down what you truly want there.
And I think historically, a lot of times we've seen, and certain state practices, this is more common as well, is that they will appoint their funeral agent in their will. I am anti that practice because let's be real, at the time those decisions are being made, almost no one is looking at the will.
And often the will is in a safe deposit box or a safe
Right.
that's locked and nobody can find the
Mhm.
combination.
Yes.
There's any number of things that can go wrong, but given that a will is a document that we keep so safe and protected, in the heat of everything happening and needing to make those decisions,
Yep.
nobody's thinking to grab the will,
Yeah. Yep.
especially not the person who's actually making these decisions. Maybe somebody is, but it's probably a second or third cousin who's hoping they're in the will.
And that's not the person you want
No.
to be doing that stuff. Other thing, if you have religious preferences. So I know, for example, Catholics like to remind people, hey, I need last rites. Jewish people will often remind people, hey, I need to be buried in the Jewish cemetery. I'm
Right.
sure there's ones for Muslim people as well. I haven't had many Muslim clients, so I
Yeah,
don't
and
know
in there are religions where it's absolutely under no circumstances is there to be an autopsy, like that kind of stuff, where
that.
my
Mhm.
body has to be kept entirely intact
Yep.
for my religious beliefs
Yes.
to apply, those kind of
Yeah.
things.
So it's really important that if you have those things, please put them there, because if your primary agent isn't there for one reason or another, or the person you've chosen isn't as familiar with that aspect of your life, like they might not do it. So definitely put those types of things there as well. And then now we're on the second page. And this is the
Woohoo!
last question to answer. And so that is organ donation. So upon your death, do you want to make an anatomical gift? And the first box, any organ or tissue, that's traditional organ donation that we all commonly think of. The my entire body is you are donating your body to science. So what does that mean? That means you could be a cadaver at a medical school. That means you could have different pieces of you at different places in the world for research. In Knoxville, I don't know what it's formally called, I'm sorry, but there's something that is generally referred to as the body farm, where they do forensic research and bodies can be left exposed or buried, or it could be that type of situation, which maybe you are fine with that, maybe you aren't. So just understand that's what it means when you're marking your entire body. You can also do
Mhm.
no organ or tissue donation, or you can specify what you do and don't want as far as donation goes, and then you sign it. And there's a couple options in Tennessee for signing. You can either have two witnesses there. They cannot be your agents. Don't have your agents be your witnesses. And you can also have it notarized. So it's two witnesses or a notary, because in our office, this is our form. It's just got the notary form. But the two witnesses is also an option. Other states, if you're in another jurisdiction, the two witness thing is very common. So if you are listening to this and you are not a Tennessee person and you are not having this formally notarized, I would strongly recommend you always notarize and have two witnesses, because at least in all my jurisdictions, that's got you covered either way, whatever the rules are. So Erik, what are some questions that people often have about this that you don't think we've covered?
So people often ask me now, okay, if I put down that I don't want certain treatments and I get in a car accident or I have a stroke tomorrow, on my way out of here, I step off the curb to walk across the street and I get hit by a bus, is this form going to apply?
Yeah.
And generally the answer is going to be no, because like we talked about earlier, that with that flowchart model, right? If we're going from are we in one of these conditions that are unacceptable? And the answer to that is no, then we don't worry. We ignore the rest of the form. None of the rest of it applies, at least as far as what treatments you would want and if you would want to pull the plug. Now, if after in your recovery at the hospital from that it ends up being determined that you are in one of those conditions, then we move into that. But in that immediate, the paramedics are showing up to the scene of the car accident, they're going to do CPR. They're going to do their job. They're going to get you to the hospital and then let a doctor make that call. So then another one, and I'll let you speak to this, Kathleen. Is this a DNR? If I sign this, am I
DNR.
all of a sudden DNR altogether and I don't and nothing else needs to happen and I'm in the hospital and I'm stage 4 cancer and I code, is this form enough?
Yep. So that's a really good question. So is an advanced directive a DNR? The answer is no. DNR being a do not resuscitate order, which I think is more of a vernacular term. I don't think that's a formal medical term. I can tell you where we are. What happens is if you have an advanced directive, and let's just say you're all no's, so you would want to be a DNR and you are in the hospital, right? Your agent, and assuming you don't have capacity to talk to the doctor yourself, your agent would use your form that you filled out, showing the doctor the all knows, and the doctor would put an order in your file called a post order that would say they are a do not resuscitate. They do not want interventions, right? So there is an order that would need to be put in. And this is not like a one-time order because every time you go to the hospital with the record keeping systems they have, they need to have a new order, I believe, every single time. I'm not aware that they are able to do an order that lasts longer than whatever that one stay is. No, this is not a DNR. If you are a person, and I have had a couple of these clients who they never want to be taken to the hospital. They are literally like, the only thing I want to let you do is pick me up off the floor and put me back in bed if I fall down. This form is not enough, right? You need to, and to be perfectly frank, I can't guarantee you that you can have your wishes because there is such a push, like I said, towards keeping people alive, towards treating people, towards giving people interventions, right? So you need to have this posted on your fridge. You need to wear jewelry. You need to communicate it to everyone around you if those are in fact your wishes. Just, yeah, the force of the system behind things and everybody wanting to do the right thing and not get in trouble, that's what's going to happen. So that, any
Yeah.
thoughts on that, Erik?
Nope, I think you covered it pretty well there.
All right. So we hope that you guys found this helpful and thorough walkthrough of the Tennessee Advanced Directive for Healthcare. And again, even if you're not in Tennessee, I think this is a great form to go through. I made my parents, and I'm so thankful I did go through this form because it's way better than the North Carolina one, just saying. And it'll just make you have more productive, useful conversations, I think, with your loved ones and the people who will be helping you. So on that note, hope you guys have a great day. Thanks. Bye.